There are so many challenges, it's going to be hard to summarize them all in a short period of time. The two biggest and obvious challenges are that these are incredibly rare diseases. In the United States, only about 10,000 to 15,000 cases per year. And these are incredibly heterogeneous diseases, very diverse. We now recognize nearly 36 kinds of T-cell lymphoma. So those two challenges make it very hard to develop a consensus around how best to manage these diseases. And in fact, the lack of a consensus on care, be it in frontline or relapse setting, is probably the third big challenge. We have regimens that are predicated on combination chemotherapy developed in the past. They have been, by default, become the new standards of care. But those three aspects conspire to create enormous challenge. The next big category of challenges revolves around biology. Many cancers have clear biological underpinnings, and we can point to targets, we can point to networks. In T-cell lymphoma, that has been slow to evolve. Pathologists have done a great job over the last 20 years, really defining the different subtypes, defining their unique molecular profiles. And that, coupled with some new drugs and the information from those new drugs, has informed us that maybe there is a biological basis for these diseases, and that biological basis may be its underlying dysregulated epigenetic biology. And so one of the great challenges then, what are the drugs we have available to target that biology? Are those drugs optimized? And in my opinion, from the pharmacologist perspective, they're not optimized. And from the point of view of how do we understand the scientific basis for how to move those drugs forward, scientists need good laboratory models. They need cell lines, they need mouse models, and they need know-how. And that represents a really huge challenge. So I think if we can find a way to think about how to survey these drugs that try to target the critical underlying biology, we'll be able to make progress. Well, unfortunately, we haven't made many advances over the last 30 or 40 years. CHOP-based chemotherapies are widely regarded as standard, and in many parts of the world, those patients go on to receive an autologous stem cell transplant in first remission. That's probably the universal standard in some form. In my practice, we use clinical trials. Not everybody has access to clinical trials, and so that becomes harder. But where we can collaborate in a country or in a region or a city with colleagues that do have clinical trials for these diseases, I believe a clinical trial in the frontline and the relapse setting should be the standard of care until we define better standards of care. In fact, if you look at the NCCN criteria, almost always the criteria from North America, Europe, even Asia recommend clinical trials very early. Regarding immunotherapy, I think it's a fascinating area. CAR-T has taken a long time to develop in these diseases, but I think there are lots of interesting advances and developments by various groups around the world that suggest that those kinds of treatments will soon become available with meaningful clinical benefit for all patients. New hope is tied to the last point, and the new hope has to be based on research. And so the key, whether you're a patient, a government, physicians, foundations, is to make sure that we allocate dollars for that research. There are very few doctors around the world that do research in these diseases. Lots of doctors treat, a lot of doctors will put together clinical trials. But fundamental research on how to exploit the biology to find new therapies, that's rare. And I think the government and physicians with interests, including those institutions where the physicians work, is going to become very, very important to coalesce a singular community. Working individually is not going to do it. We're going to have to work as a team. But I think for me it's research and trying to figure out what's the biology worth targeting, and then comparing those new therapies against our standard of care in randomized studies in the clinic, which isn't hard but can be done, is going to be the only way we make those advances.